So my name is Richard Kellermeyer, and we're here with the Pediatric breakout session for the summit, and we hope to increase our pediatric presence and advocacy for our pediatric patients suffering from Clostridium difficile infection. I'll briefly introduce the group, and we apologize, but we will have to make the session shorter, so we'll try to shorten our talks, so that might be a little bit of adjustments here. Maribeth, if you could take me to the third slide. So again, I'm Richard Kellermeyer from Texas Children's Hospital. I'll talk a little bit about diagnostic and clinical challenges for Clostridium difficile infection in children. Dr. Ruan will talk about alternative diagnoses in children when we're facing suspected recurrent Clostridium difficile infections. Dr. Nicholson will cover the national trends briefly in children with CDI and how we approach therapies, including fecal microbiota transplantation. Dr. Stacy Kahn from Boston unfortunately couldn't make the meeting. She had a family emergency. And Dr. Hourigan, who is going to the NIH to lead microbiome research there, will talk a bit about regulatory issues around fecal microbiota transplantation and the future of microbial therapeutics, focusing on children. So I was going to talk about the microbiome a bit, but you've heard a lot about this, so we'll just skip this slide. Even this one we'll skip. It's a complicated, big organ in our body, which is very important from the pediatric perspective that when we're conceived and we are in the womb, in a largely sterile environment around birth, we are exposed to first the bacterial environment of mom, and then of course the whole environment. And what you can see on this slide is the colors represent three different populations around the world: USA, Amerindians, and Malavians. And this is the stool microbiome in one little sphere of a patient or a person. And what you can see on the right is that the microbiomes vary a lot at birth. It's almost like a random development or establishment of the microbiome. And rapidly as the microbiome evolves, this individual difference decreases with time, and it settles out by about 3-4 years of age. On the lower slide, and Dr. Nicholson can hit that, when we're looking at the richness of the microbiomes, how many bacteria and other organisms are in one's gut, that rapidly increases from birth, because again, from a sterile environment, we rapidly establish our microbiome. Then it kind of settles out around 3-4 years of age. So the first 3 years of life are very dynamic in respect to the microbiome, which creates a certain importance, especially we'll see later for Clostridium difficile. And it is within this complex microbiome that we have to deal with Clostridium difficile, which is an opportunistic pathogen that is an anaerobic spore-forming bacteria. We've heard a lot about this, so we've done talk, but it really takes advantage of situations where in this host microbiome axis or complex interaction, there is a problem. So abnormal or perturbed states, antibiotics are really big in this, but also diseases such as inflammatory bowel disease, cystic fibrosis in children are very important aspects that we have to consider. And Clostridium difficile likes those environments when this interaction is perturbed in these disorders. And of course, you know that it can cause antibiotic-associated diarrhea, and if it goes further and more aggressive, then colitis and sepsis and even death, unfortunately. So in order for us to really be able to, Maribeth, diagnose Clostridium difficile, we heavily rely on laboratory testing. And I'm sure this has been covered as well by others. But what is important to know that there are many tests and none of them are perfect. So C. difficile culture is less commonly used right now. The toxigenic culture is great, and it has high sensitivity and specificity, so it's a wonderful test, but it's very complicated to perform, and it's not really used in the clinical setting. Only when we want to do confirmation of ambiguous cases. that goes to the C. difficile cytotoxin neutralization assay as well, the CCNA, which is actually the reference methodology currently, the gold standard to diagnose Clostridioides difficile in the laboratory. Then there is a GDH test, which is very sensitive but not very specific for Clostridioides difficile, especially the toxigenic Clostridioides difficiles. We use that as the first screening test. And the toxin EIA is becoming less used. That was the most commonly used test in the laboratory. It is now in algorithms, as you'll see. And then most commonly, most labs do these days the nucleic acid amplification test, which is PCR, as you've heard again in the COVID pandemic. You've heard about PCR testing a lot, and that is used commonly in the lab. So again, all diagnostics methods have flaws, and even the nucleic acid test is increasingly becoming recognized that it may be too sensitive for the clinical arena, and for this reason, there are these algorithms that have been developed. Next slide, please. And so it's very important for us to recognize that we have to test patients with diarrhea because the testing becomes even more complicated when we're facing non-diarrheal stools. And in the first step in the laboratory, they perform these very sensitive but not too specific tests, the GDH, and or the nucleic acid test, which is both sensitive and specific, but again, it's too sensitive. When these tests are negative, then we think Clostridioides difficile infection is unlikely. When they are positive, then it's a good idea to do a confirmation test with something that is very specific. We talked about this toxin test. If that is positive, then currently, at least in this algorithm, we consider the Clostridioides difficile infection in a diarrheal patient confirmed. When the test, however, in step 2 is negative, then we rely on these more elaborate, difficult tests to do in every laboratory, which is either the culture or even the cytotoxic neutralization assay that we spoke about. And based on that, you kind of see how even the diagnostic dilemmas emerge with Clostridioides difficile infection. Next slide. For children, as again we mentioned, we have to take other epidemiologic issues into consideration because of this rapid development of the microbiome that you see and we've seen before. And along with this development, next slide, what we go back, please. That what we've recognized is actually Clostridioides difficile is a part of this developing microbiome, especially in ages less than 1 year or less than 2 years. And if we test children less than 1 year of age, almost 100% of them can carry Clostridioides difficile in their stool. So it is very important to recognize this conundrum that if we face a child who's 1 year old has diarrhea and Clostridioides difficile is in there, we don't know if it's a pathogen or it's a disease causing or just being there, like a carrier state, we call that. Go to the next slide, please. So we have to really interpret the tests and also the clinical scenarios with caution. And so at least expert opinion from infectious disease colleagues state that under 2 years of age, one has to be really cautious in diagnosing Clostridioides difficile infection. We haven't even talked about, we don't know how the toxin gets sensed in the body. And it seems that this sensing develops by age, and before 1 year of age, we are not even sensitive to the toxin of the bacteria, it appears. Next. So because of all these, I just wanted to emphasize how difficult it is to make a diagnosis. There was a study in hospitalized pediatric patients between 1 and 18 years of age back in 2014, and they did a study on patients in the hospital who were symptomatic with diarrhea, and of course, Clostridioides difficile infection was considered in them, and patients as well who were asymptomatic, and they just tested their stool and to see with this nucleic acid or the PCR-based testing what happens. And that the researchers actually found that more patients who were asymptomatic were carriers or harbored Clostridioides difficile by the PCR-based testing in their stool than those patients who had diarrhea. And just very recently, Dr. Nicholson led this study that was published in 2021. She took this question beyond the 2014 article, and she did this algorithmic testing for children who were symptomatic, had diarrhea, had underlying disorders that made them prone to develop Clostridioides difficile infection, and similar patients who were asymptomatic and doing well. And so she first tested the patients, or the group first tested the patients with this nucleic acid based testing, or the PCR test. And if the patients were positive, she took the algorithm further and tested either with the toxin enzyme test, or with even with the gold standard, the cytotoxic neutralization assay. And neither of the tests could make the diagnosis of Clostridioides difficile infection between the symptomatic and asymptomatic patients. So if we look at this algorithm, actually the algorithm didn't work in the diagnostic testing base, because if we go to the step 2, and the patients who are asymptomatic are tested with the toxin, or even step 3 with the cytotoxic neutralization assay, the question is still there whether they have true infection or not. So next, there's the question mark there. So the conclusions I would like to highlight here is that Clostridioides difficile is an opportunistic pathogen. You really have to consider, especially in pediatrics, the underlying problems, and also that it can be part of a normal microbiome in an otherwise considered to be healthy or asymptomatic person. And C. difficile is very commonly challenging to diagnose, and therefore it's challenging to decide to treat or not treat as well. And because of these issues, we really have to rely on shared decision-making between astute clinicians who take all these considerations into effect and inform patients to effectively combat this really big problem currently in the United States. Thank you for your attention. So Dr. Wenly Ruan will give her presentation.
Awesome. Hi, guys. So I'd like to thank everyone and the Peggy Liz Foundation for giving me the opportunity to present alternative diagnosis in children with suspected recurrent C. diff infection. For those of you who don't know me, I'm a pediatric gastroenterologist here at Baylor College of Medicine, Texas Children's Hospital in Houston, Texas. The following just are my disclosures. So I'm going to start with just a little bit of background. As we know, what occurs in Clostridioides difficile infection, or C. diff infection, is that normally you have the GI tract, which lives harmoniously with gut microbes that are normally there. With insult or exposure to antibiotics, there can be alteration of the normal intestinal microbiota that allows for penetration into the mucus layer of the intestinal tract by C. diff. This then adheres to your intestinal epithelial cells and can then produce and release toxins A and B, which then has many effects, including causing inflammation and disease, which leads to symptoms that you see in C. diff infection. So with C. diff infection, it can cause a spectrum of symptoms, including diarrhea, colonic inflammation, and in severe cases, it can be associated with toxic megacolon, which is when your colon doesn't work as well, it widens and can increase the risk of rupturing. In other severe cases, it can lead to sepsis, hospitalization, and even death. And so that's why it's really important to optimize treatments for C. diff infection. And largely in the past, metronidazole or Flagyl has been the main antibiotic agent of choice for the treatment of C. diff infection. With new evidence emerging, we know that now that vancomycin and fidaxomicin is more recommended over metronidazole for the treatment of an initial episode of C. diff infection. For severe C. diff infection or fulminative C. diff infection, vancomycin is still the regimen of choice. And in cases where there can be ileus or where there's not good movement of the bowel, IV antibiotics and rectal antibiotics can also be used. However, despite these treatments, we know that recurrent C. diff infection can occur due to the presence of C. diff spores remaining after antibiotic therapy. So 15 to 20% of patients who are treated for an initial C. diff infection can experience recurrence of infection. And of those patients, 45% can have second recurrence of infection. And there's many different regimens for the treatment of recurrent C. diff, including changing from the initial antibiotics to a different antibiotic regimen, vancomycin tapers, and rifaximin. However, recurrent C. diff can still be very difficult to treat despite these available microbial regimens. And this has therefore led to an increase in incidence and recurrence rate of C. diff infection in both the healthcare setting as well as the community. And so that has really resulted in fecal microbiota transplant, or FMT, as an effective treatment for consideration for recurrent C. diff infection. And what occurs with FMT is that healthy stool from healthy patients are given to patients who have C. diff infection. And the stool from these healthy patients consist of normal healthy microbes in the gut, which then can go on to replace the bad bacteria that may be present in the patients with infection, and allows that healthy bacteria to grow and prevent C. diff from recurring. What we know is that FMT has resulted in durable cure of C. diff infection in 80% of cases in previous studies, and it commonly outperforms antibiotic strategies in adult randomized controlled trials. And so as a result, there's been an increase in number of patients who are referred to centers and programs that can perform FMT. However, diagnosing C. diff infection and recurrent C. diff infection, as Dr. Kellermeyer had mentioned before, can still be challenging. What we know is that in adult patients, a significant number of patients, roughly about 25% of patients who are referred for FMT for recurrent C. diff, can have alternative diagnosis despite positive C. diff testing. And that can be alternative diagnosis such as inflammatory bowel disease, irritable bowel syndrome, celiac disease, and other diseases. Additionally, asymptomatic individuals can also be colonized by C. diff and still test positive for the bacterium, which can, even though they might not have active C. diff infection. Furthermore, FMT has been associated with severe infectious complications, and so it's therefore really important when you're considering FMT for a patient to assess carefully what their symptoms are, and to also assess for potential alternative diagnosis. So while we know the rate in adults, we really don't know what the rate is in pediatrics. And so that is where I'm going to start by talking about our project at Texas Children's Hospital, where we looked at pediatric patients who were tentatively diagnosed with recurrent C. diff and referred to us for FMT evaluation. And we basically defined recurrent C. diff as based on medical history, and they had to have failed at least 2 complete treatment trials. Patients who were not referred for recurrent C. diff or didn't have positive C. diff testing weren't included, and we basically looked at their characteristics to evaluate what they ultimately were diagnosed with, whether that's recurrent C. diff or alternative diagnoses. And so what we saw at our institution was that there were 82 patients who were referred for FMT here. Of these patients, 8 of them didn't actually have C. diff testing that was positive, so we excluded them, which left 75 remaining. And of these, 6 didn't have recurrent C. diff as the true diagnosis and a referral reason, and which left 58 patients who were referred for FMT with possible recurrent C. diff. We then looked at those patients, and of these 58 patients, 45 were confirmed to have recurrent C. diff infection, and 13 patients actually had alternative diagnosis other than recurrent C. diff. And so I'm just going to show you briefly an overview of what the characteristics of these patients were. So I'm just comparing the 2 groups of patients, those that have confirmed to have recurrent C. diff and those with alternative diagnosis. And what you see is that there's really no differences between, their demographic characteristics, so race, ethnicity, gender. In terms of prior medications, more of the patients who were confirmed to have recurrent C. diff were on immunosuppression compared to the others, and they tended to have more episodes of C. diff infection as well. In terms of who referred them over, more of them tended to be referred from gastroenterologists or primary care physicians with a recurrent C. diff group compared to the alternative diagnosis group. So then I wanted to take a little bit closer look at that 13 patients who were diagnosed with alternative diagnoses other than recurrent C. diff. And those 13 patients, the breakdown is in this table. So the most frequent alternative diagnosis was actually constipation, leading to overflow diarrhea in concomitantly C. diff colonized patients. So they tested positive but didn't actually have active symptoms and actually had constipation, followed by unrecognized inflammatory bowel disease, ulcerative colitis, Crohn's disease, then abdominal migraine and milk protein allergy. So in these patients, alternative diagnosis directed treatments resolve the clinical concern for C. diff infection. This differs a little bit in the breakdown from the adult study that I mentioned before, where their most common alternative diagnosis was irritable bowel syndrome, post-infectious IBS, IBD, and others that are in this chart. However, I just want to make the comment that overall, the rate of alternative diagnosis between adult and pediatrics were very similar. It was about 20-25%, which is not a small number. So this just emphasizes that you should look for alternative diagnosis and think about other reasons for symptoms other than recurrent C. diff for some patients. So then looking at the patients that actually did get confirmed recurrent C. diff, 29 or 64% actually received FMT and had improvement of symptoms. 16 of these patients actually did not receive FMT. So I wanted to take a closer look at these patients. And so of these 16 patients that did not get FMT, 12 actually improved with just optimized C. diff infection treatments without FMT. 2 had resolutions of symptoms prior to the visit, and 2 were lost to follow-up. And so what this emphasizes is that even before considering giving FMT, it's important to evaluate what regimens patients were on before and what you were on before to try to see if there's ways to better optimize treatment before going towards FMT. And so obviously this is a study at our institution, and it doesn't account for necessarily a medication adherence at home, and there's obviously varying degree of historical information from patients before, and more relevant now is that due to the pandemic, FMT at least our institution has been on hold due to safety concerns. But I think the big points to take away from this is that recurrent C. diff can occur and is increasing. FMT referrals occur because FMT has been shown to be very effective, but before giving FMT, it's important to consider alternative diagnosis and optimizing treatments beforehand. So I'd just like to thank Dr. Richard Kellermeyer, who's my mentor for IBD at Texas Children's, and I'd like to thank everyone for taking the opportunity to listen to me today.
I'm going to focus on just some of the alterations in C. diff incidence and treatment in children. And so I think a lot of us are familiar that in the last decade or so, or 2 decades really, there was a dramatic increase in the incidence that we were seeing, and leading to really some staggering numbers. Ultimately, C. difficile in 2013 got listed as a urgent level threat because of the number of infections and the number of deaths associated, as well as the extreme excess and medical costs per year. And so this wasn't just a problem of adults. So I think previously this was thought that C. diff was something that happened in the elderly or those with other comorbidities, but we were seeing these same dramatic increases in our pediatric patients. And this is data of hospitalized children, but I could show a similar schematic for community-acquired disease. We were seeing, again, dramatic increase. And so there was many thoughts about the reasons for this, and thought about alternative strains that were circulating, or the use of broad-spectrum antibiotics, which were more common, or significant immunosuppression. There's also alterations in testing that have been mentioned that could have been leading to some of these rise, but it was certainly clear that something needed to be done. And so there's been a lot of effort in recent years to change our infection control protocols, as well as to decrease the use of broad-spectrum antibiotics. And I'm excited to say that I think now we're starting to see that some of those changes are being borne out in terms of what we're seeing about incidence. And these are still staggering numbers, but this is, again, substantial improvement from what we had been seeing before. So this was published in 2020 in New England Journal of Medicine, demonstrating an overall leveling off of the incidence And when they adjust for testing, they actually see some decrease in the incidence of C. difficile in the United States. So again, good news after really some staggering numbers. We looked at this also through a partnership with the FIS database. And again, we see this overall leveling or decrease in the incidence of C. diff in our pediatric population as well. So we're not there yet, but this is really encouraging data. I'm going to focus really quickly on just some treatment updates because I want to leave Dr. Hourigan some time. As mentioned before, we're seeing increased use of vancomycin over metronidazole, even though metronidazole remains in the recent 2017 guidelines as an option for first-line therapy in children. Vancomycin use was recommended in adults, and that's really kind of taking over more first-line therapy. We were excited last year that fidaxomicin, which is a really narrow-spectrum antibiotic, was approved for pediatric use, and we're showing we're getting increased data on the use of FMT in children. I'm going to skip this slide. So this we published last year looking at a large cohort of pediatric patients, the largest one that had been published to date, looking at 335 pediatric patients, and we had 81% cure after a single FMT. It became 86.6% if the FMT were repeated. And this is first about 50% of patients who are treated again with antibiotics will have a successful outcome. So again, substantially more effective, though we certainly saw some severe adverse events, 2 of which were FMT related. The safety of FMT has kind of garnered some increased attention, which Dr. Hourigan is going to talk about some too. There was a safety alert in June of 2019 where 2 immunocompromised adults received FMT from a donor who ultimately was deemed to be positive for these multi-drug resistant E. coli, and unfortunately 1 patient died from this. So the screening was changed that all donors had to be screened for multi-drug resistant organisms. And then in the setting of the COVID-19 pandemic, where we know that SARS-CoV-2 can be detected in fecal samples, though we don't know if it can be transmitted that way, additional testing was recommended. And so with this, we surveyed our GI community to see what this meant in terms of alterations in current practice. And I'm really just going to highlight the fact that since COVID-19, now 61% of programs have halted as of January of 2021. And so we understand that there's increased regulatory guidelines. And with that, the accessibility of FMT for our pediatric patients is currently extremely limited. And this is going to be even more challenging as OpenBiome, the largest commercial stool bank in the United States, only plans to provide FMT products through the end of this year. And that's related to increased costs of screening. They also said they've mentioned that there's increased biotherapeutics that are going to be approved. Unfortunately, these have not been yet studied in children and will not be available for our pediatric patients. And that's why we're excited to continue partnerships with groups like this advocacy group to really ensure that our pediatric patients can have safe and effective therapies. And I'm going to hand things off to Dr. Hourigan.
Good morning, everyone. I am excited to talk about the future of microbial therapeutic research for C. diff in children, and we're going to whiz quickly through these slides. As Dr. Nicholson said, there have been lots of changes and regulatory considerations that we need to account for with fecal transplant, including that the new donor screening because of the FDA safety alerts in the COVID-19 pandemic. And as mentioned, this leaves our pediatric patients with recurrent C. diff in a very difficult position because we have decreased access to FMT. And although promising microbial therapeutics, which we're going to talk about in a minute, are coming down the line, it's going to be a long time till our children can receive these. And so what are microbial therapeutics? So you can consider them as bugs as drugs. So they are rationally defined human-derived bacterial consortia. What does that mean? So this is drugs made from human stool where a bacteria or a group of bacteria or group of bacterial spores are identified that are effective to treat C. diff, and then these are reproduced in a regulated, standardized way in the lab. And compared to FMT, they have the potential for increased standardization, safety, and practicality. We'll just skip this. It takes a while to develop microbial therapeutics into an effective treatment that can be used in humans. However, there are several candidate microbial therapeutics that have got to the stage of clinical trials for effectiveness, including products by Seres Therapeutics and Rebiotics. And excitingly, some of these products have been given fast track designation by the FDA, which means they will probably be approved by early next year. However, there are certain considerations for when using microbial therapeutics for children. So most of those that are in clinical trials are given by capsules or enemas, which are just not child-friendly. In addition, with all medicines, not just for C. diff, there are inherent delays with clinical trials in children and subsequent FDA approval, partly because trials in children do not make money for drug companies. And so really we're left in this difficult situation of lack of access to effective treatments for recurrent C. diff for children because of lack of access to fecal transplant and delays in microbial therapeutics being developed for children. So we also have to remember children are not small adults. As Dr. Kellermeyer touched upon, we have a rapid developing microbiome in the first 3 years of life, which then influences immune development. Also, as we see with other drugs, children have a differing metabolism in response to drugs. And so we don't even know if these microbial therapeutics would be safe or effective in children, which is why we need dedicated pediatric trials of microbial therapeutics. In addition, all the microbial therapeutics undergoing trials right now are derived from the adult microbiome. And this is the same question that we have with fecal transplant when we use an adult donor to a child recipient. Does giving an adult microbiome to a child in a period of critical microbiome and immune development cause accelerated immune aging and other problems? And should we actually be using age-matched products in children and develop these products from the children's microbiome, not an adult's microbiome? So what's better than treatment for C. diff is prevention of C. diff. And as Dr. Kellermeyer already talked about, in infancy, between 35 and 70% of infants carry toxigenic C. diff. Risk factors associated with carriage include maternal factors such as prenatal and peripartum antibiotics, cesarean section delivery, and infant factors include formula feeding rather than breastfeeding, hospitalization in the neonatal intensive care unit, and antibiotics. All of these have been associated with microbiome imbalance. So our team, with funding from NICHD, are taking a deep dive into the microbiome of 600 infants with serial stool samples, looking at C. diff carriage and microbiome components that are protective against this carriage to see if this can give us a clue to lead to products that can prevent C. diff in children. Thank you all.
I think we would open it up to session or open it up. As you've seen, there are microbial therapeutics coming down the pipeline, but unfortunately those are tested in adults. And we are left in a pretty big conundrum currently this year and moving forward with our pediatric patients who are actually many around the States are waiting on antibiotics, like long-standing antibiotic treatments, are awaiting the potential to be treated with fecal microbiota transplantation. We just don't have the safety measures by which we can proceed, nor we seem to be having the potential for these microbial therapeutics down the pipeline soon for our patients. So we would really ask for help here at the summit as well. For advocacy towards legislation and even therapeutical companies.
I think one of Dr. Hourigan's last points was too that, as Dr. Kellermeyer mentioned, these aren't being studied in children, and they're also not easily administratable to children. So usually they're enema and capsule versions, which are a little bit difficult to administer to a lot of our pediatric patients. So we're, as pediatric providers, we're definitely worried about, where this future might go.
I'll let Dr. Nicholson answer the question about the leveling of C. diff in children.
Yeah, so we are seeing a leveling off in children, and there's actually maybe a slight decline, which is exciting. And I think, again, born out of a lot of the antibiotic stewardship programs that have been such a focus, and really just doing narrow spectrum and limited spectrum on our antibiotics. But I don't think we have great data thus far out of the UK in terms of pediatric populations.
To my knowledge, there are no industry-sponsored trials that are focusing on pediatrics at this stage with the new therapeutics. We have to recognize that our population is, compared to adults, is extremely small. So that's the biggest hurdle from especially startup companies who are usually managing these. Their finances are very limited, and it's really tough to involve the pediatric population.
Well, thank you all for involving us. I feel like this was an abbreviated but fun presentation to be a part of, and we're excited, I think, to partner with you guys in the future.
Yes, thank you very much. It was great.
Thank you, guys.